Hello everyone, my name is Rachel Khan and I'm the Research Communications Manager at Blood Cancer UK, and I'm very privileged today to be joined by Professor Jude Fitzgibbon, who is a researcher who specialises in lymphoma at Queen Mary's University of London, and Jude is one of our incredible researchers who has been funded by Blood Cancer UK for, 14 years, Jude?
Yes, absolutely, 14 years.
14 years, and we've recently funded him to carry out another piece of research, which essentially is going to look at how changes to the coating of our DNA can cause and affect certain lymphomas. So without further ado, Jude, could you give us a little bit of an explanation of your research and what you're planning on doing?
Yes, for sure. So I work on a number of different lymphomas. One is called follicular lymphoma, and another is diffuse large B-cell lymphoma. And together they probably represent about maybe 70% of all non-Hodgkin's lymphomas. And several years ago, we got some new technology which allowed us to sequence tumors very, very effectively. So I think everybody here will have heard now about sequencing of COVID viruses and how you can look at variants. Well, you could do that, in the last 10 years very effectively in tumors. And at Barts, we had a very large repository of biopsy samples. So when you as a patient might have had a biopsy taken, part of that would go for research purposes. And so we could sequence these biopsies. And what we began to see was that most patients, maybe 80% of patients with follicular lymphoma, probably about 40 to 50% of patients with diffuse large B-cell lymphoma, had mutations in genes. These are just pieces of information that encode components of what we call the epigenome. And that's essentially genes that turn on and off gene expression. What we're beginning to see is that these genes actually coat the DNA, and that coating actually regulates how a gene is turned on and off. And excitingly, there's a new therapy called EZH2 inhibitors. It's called tazemetostat, which can reverse the effects of these mutations. So it's one of the first examples in lymphoma where you can perform something called precision medicine, where you can probably identify patients who might benefit from a certain therapy because they have a mutation in a gene, and actually treat those patients with this particular new inhibitor. And what we're trying to do is to see, can we expand the number of patients, and we can select patients for specific inhibitors that essentially will remove or put back on the appropriate coating onto the DNA so that it expresses perfectly.
That sounds really, really interesting. Oh, just got a bit of feedback there. And it's really interesting how, how our kind of DNA needs to exist in this perfect equilibrium to be able to do its job properly. I always kind of think about it like little light switches that sit on top of our DNA that are either in the on button or the off button. And if they get stuck in the on button, then it can cause things like cells to divide and grow uncontrollably. And it's great that kind of you're essentially putting something in there to kind of get someone to turn that light switch button the other way and turn it off again. Is that correct?
I think that's a really nice way of thinking about it. And there's lots of different kind of ways of thinking about it. In that, we're coming up to the Euro Football Championship over the weekend, and many people will be dusting off their England tops. And so you can imagine that if you're in a stadium whereby you've got English supporters wearing English tops, you've got the other team's supporters, let's say Scottish or Welsh supporters, wearing their tops, that depending on what happens on the pitch, a supporter will actually change its expression. It can get very excited if England score. It can get very disappointed potentially if Scotland or Wales let in a goal. And it's that control of the individual gene or the spectator, because there's about 20,000 genes in our bodies. We need to control those. It's also worth keeping in mind that every cell has exactly the same DNA. So whether you're a hair cell, you're a retinal cell, whether you're a B cell or a T cell, a plasma cell, if you're thinking towards multiple myeloma. And so therefore we need ways of how do you create identity of a cell? And that's because the genes are expressed in different ways. And as you said, it might even be a little bit more complicated than a simple on-off. You might have a little rheostat where you can actually change the expression, even just a little bit will actually make a big difference.
So they're like they're like the light switches that you can turn up and you can turn down, and that will influence the level of gene expression. That's really interesting. It's not a simple switch, it's one of those fancy twirly ones.
And in a way, because so many different factors can influence gene expression, there might necessarily be, for each gene, there might be several different switches, and each switch can regulate the expression in a certain way. But I think what's rather exciting at the present time is that we now know how these genes are important. We know all the other genes that are mutated in these cancers, and we're trying to put together the jigsaw puzzle as to how they impact the biology of the disease. How, say, for example, in follicular lymphoma patients, how some patients can stay on watch and wait for a long period of time or be in remission for 10 years and more, while other patients might respond very quickly, or not respond, or go into a relapse early. And so what we're trying to do is to understand, are these particular genes important in defining whether a patient is likely to fall into what you call a bad group versus potentially a very good outcome group.
That's really interesting. And in terms of the drugs you described, targeting these genes and switching them on or off or down or up, how can we create treatments that specifically target the lymphoma and don't affect kind of other cells in our body? Because, you know, for something like chemotherapy, the reason why the side effects are so horrible is because it targets every single fast growing cell in our body. So how can we try and do that with these potential drugs?
I think that's very challenging, because a lot of these mechanisms, a lot of these genes are important both in normal cells and in the tumor cell. And so I think it's a way of thinking about drugs going forward, that typically cancer drugs, you think of the maximum tolerated dose. The more you can give, the better, as long as the patient can tolerate that amount of drug dosing. I think going forward, and especially with epigenetic therapies, it's possible that these drugs mightn't necessarily need to be prescribed at a very high dose, but actually might work very effectively at low doses, especially when they're used in combination with other treatments. And so sometimes you can think of epigenetic therapies as being able to fine-tune gene expression, but working in conjunction with other drugs. So for example, some of these epigenetic drugs might very well work well with drugs that affect the tumor microenvironment. And so if you can combine drugs at lower toxicities potentially together, maybe you can reduce toxicity, and so therefore that you get the lymphoma benefit without the side effects. Because I think you're quite right. In a lot of these cancers, what we're finding is that the therapy in the longer term can actually lead to comorbidities and can actually affect outcome. So it might necessarily be the lymphoma itself that ultimately will be to the demise of the patient, but actually the side effects of the therapy over a long period of time.
Yeah. I think that's really important to kind of think about side effects and how we can reduce them as well. I think my next question for you would be, if we had this Zoom call in 5-10 years time, where do you think we'd be with this? Do you think we'd be treating lymphoma patients with these drugs that change these switches? Where do you think we'll be?
I think what I say to all the young researchers starting off, and I'm still relatively young myself, is the standard of care for treatment of, say, follicular lymphoma and diffuse large B-cell lymphoma hasn't changed in the last 20 years. For those patients needing treatment, it's typically rituximab and CHOP chemotherapy. And so, you know, you can look at it very simply and say that we failed over the last 20 years because we haven't been able to introduce new therapies that, as you said, either have a lower toxicity or are more efficacious. I think when you look to 5 years, I think that every patient is likely to have their tumors screened deeply from a molecular perspective, so that you actually know the repertoire of mutations that are actually present, what genes are being expressed. And by definition, then, rather than everybody being treated exactly the same, we might start identifying groups of patients that might be treated slightly differently. And I think the hope is that that will actually lead to overall improvement, whereby patients who are unlikely to benefit from a certain set of therapy, either the standard of care, might be offered something experimentally early on, or other patients and smaller groups of patients might be seen to be slightly different and to be treated in a more tailored way. And one of those examples could very well be that some patients may benefit specifically from these epigenetic therapies that actually turn on or off gene expression in a very specific way.
I think that's a really good place to hope to get to in 5 to 10 years' time. And yeah, I definitely agree with the importance of sequencing and understanding everybody's disease, because, you know, whilst you're put into one class of either follicular lymphoma or diffuse large B-cell lymphoma, every tumor is very individual, and that's the case for all cancers, not just blood cancers. So yeah, hopefully we can be doing that in 5 years, 5-10 years.
And I think what Blood Cancer UK has done very effectively of late is to try and educate the UK community in relationship to the signs and symptoms of both lymphomas and leukemias. Because the earlier you diagnose some of these cancers, specifically the aggressive ones, the more likely is that the existing treatments and the management will be more effective. And I think there's also COVID issues, I think, that the Blood Cancer UK are defining, which in a way could have longer term impact in relationship to how certain patients might respond to certain therapies. So, you know, the use of maintenance rituximab is one area that could potentially change based on the introduction or the prevalence of COVID in the population. So I think Blood Cancer UK are working fantastically well in supporting researchers, but I think it's worth shouting out the roles that they play outside of that in educating the community to the importance and the specific features of many different blood cancers as well.
Thank you. That's great. Thank you. It's great to hear. And my last question for you would be, what is your message to our community? What would you like to say to them directly?
Well, first of all, I go back 14 years as a young researcher in Queen Mary University of London in the Barts Cancer Institute. And I got a grant from Blood Cancer UK for about £160,000, which is a huge amount of money. But it allowed me to publish my research, specifically on EZH2, and to show that the mutations in EZH2 occurred in about 25% of follicular lymphoma patients. And that information was critical along a longer pipeline, where now EZH2 therapies are not only in clinical trials, but have been licensed for the treatment of relapsed refractory follicular lymphoma in America at the present time. And along the way, I think it's allowed me to train a lot of new researchers who've gone on to either start their own groups or to work more widely in the scientific field. And this couldn't have been done without the support of Blood Cancer UK and their commitment to all types of researchers, whether they're early career researchers, mid-career, or later researchers. And so I'll be eternally grateful to what you've done and what you've allowed us in the UK per se to show that we're really internationally competitive and making a difference in this particular cancer area.
Yeah, and I think to all our community watching or listening at home, thank you, because none of that would be possible without any of your support. And Jude is a fantastic example of one of the researchers that Blood Cancer UK have supported over 14 years, and you can kind of see where his initial research has gone from and where we are today. And we're really proud to have been on this journey with you, Jude, so thank you very much. and good luck with your new research project. Please keep us updated on what's happening. We'd love to hear, and I'm sure all our supporters at home would love to hear as well. So thank you very much.